Some of my paramedics turned RN friends. We was all talking about how we didn't have an accurate view of nursing before we became nurses. And we all kind of moved around to different areas before finding our fit. Some still haven't found it. Have a friend of mine recently that decided he was just going to drop out of healthcare altogether because he couldn't find his fit. And I know for me, I have experience in the ED, step down critical care, surgical services, endoscopy, care coordination, and case management. What I wanted to do over the next several podcasts was kind of share with you my experiences and also from a paramedic perspective. And hopefully, this will enlighten you. So, when you're thinking about coming into nursing, you have a good idea what the area looks like and maybe to see if that area could fit you. So, welcome to my podcast. In school, I recognized that the nursing assistants or the students that had experience already being maybe certified nursing assistants or unit secretaries on the floor, they kind of already knew which areas they wanted to work in. But for us medics, we were kind of always stuck in the either the ED or the ICU only. We kind of didn't, look at other areas. So what I wanted to do was, like I said earlier, my experience covers the ED, step down, critical care, surgical services, endoscopy, care coordination, and case management. I just wanted to kind of give you the my experiences in those areas to kind of talk about the workflow, the environment, the hours, but more importantly, the positive and negative from my experience as being a paramedic. I think that's most important. And I wanted to start with the emergency department because that was like my first choice coming out of nursing school, where I just knew that that's where I wanted to work. And for my experience, I've actually worked in a trauma center and I've worked PRN in a standalone ED. There's differences to both. As paramedics, you guys know the difference between transporting a patient from a standalone ED to a trauma center. So I'm not going to get into that. But I kind of start off with the standalone. So with the standalone, the workflow was really busy. I'm not going to lie. Sometimes it was kind of hit or miss. Some days it was busy, some days it was not as busy. My ratio was 1 to 4 patients. And whenever you hear the word ratio means for one nurse, how many patients you're responsible for. So that was mine, 1 to 4. And for me, it seemed like a step up from maybe what an urgent care would feel like. Most of the patients, they could walk, they could talk, and you get a lot of variety of patients. Some come in with maybe ortho injuries like sprains, maybe a fracture. Some come in with flank pain, which turns out to be kidney stones, or they may have right upper quadrant pain because of gallbladder issues, or they may have a headache. And but every now and then, you would probably get something serious like a weekend night GSW, or you may have a septic patient that you might have to transfer out. But in overall, the ED is really task heavy, uh, and you have a lot of patient turnover. The way it works is you have a 12-hour shift, and in that 12-hour shift, being that patients turn over, you may flip your room 3 times a shift. So that's about a total of 12 patients. The environment, it kind of depends on you and really what you focus on. I've heard of some places that have some really good leadership, and I've heard of some places that really don't. But you have some places where toxic culture exists and some where it don't. I really think it just depends on you and what you focus on. If you go in with the mindset of learning, helping your patients, it really don't matter if you have a negative staff, if you don't have good leadership. You just kind of navigate the best way you can. So the hours, most EDs pretty much have 12-hour shift. whether if you choose to work that day or nights. Some have where they schedule your shifts, and some have where it's self-scheduled. And plus on call. So let me explain to you on call. So on calls are days selected that you may be called in. For example, you may work Monday, Tuesday, Wednesday, but you may be on call Thursday. On call means that you have to be available by phone in case they need you to come in. Most of the time, if you're going to be on call, they're going to call you before the shift start, maybe because someone called out. But if not, you continue to get paid through the rest of the day, even though you're at home. You get paid a little small diff. It's not much money. I think when I was in surgical services, our diff was like $2 an hour. So for that whole day, I'm getting paid $2 an hour for being on call, just for being on standby if I get called in or not. Now, if I get called in, being that I'm going to be in overtime, of course, I'm going to get my overtime. So it's kind of a trade off. It's not too bad. Sometimes you get called in, sometimes you don't. But that's kind of what on call means. So if you go to a job interview and they tell you that you have on call, I think it's most important to ask them how many on call days you have a month. If you get to a place to where you have really, really heavy on call, you might want to rethink that situation. I know the cath lab is one of those areas that really have a lot of on call, because you may get a steamy in the middle of the night and you may get woke up and you have to be there. And not only that, you may have to come in on your regular hours and work. So just beware of what on call really, really means. Overall, I think that the standalone ED wasn't too bad. I mean, it was something that I felt was really manageable, gave really good work-life flow. And some days, like I said, it was good. Some days, maybe not so good. But the trauma center, I can tell you, workflow was really intense. The ratio was still the same, 1 to 4. Some patients are walkie-talkie, and to demented and combative, to septic and unresponsive, from chest pain and GSWs to strokes and nursing home neglect. So you get a wide variety of patients. And also some are holding patients. These are patients that's been admitted, have no beds available, leaving them in holding status. And the orders are switched to like being a floor nurse, which can be confusing. And I kind of talk about that a little later. But the environment is really high stress and it's really heavily tasked. Task to me is like you feel like you're running around in a circle, because you go from new order to new order to new order to new order. And you're always short staffed. You never seem to have enough help. And a lot of the patients, due to gaps in the healthcare system, the ED is kind of like the catch-all, because you have your indigent patients, you have your non-compliant patients, you have your uninsured, you have your undocumented, and overall patients with no primary care, and it kind of adds to the volume. And those patients are mixed in with the patients that are really sick, high acuity patients. So it can cause a little conflict. I can recall a time that I had a patient that was mad because I wasn't able to bring him a Diet Coke, is because I was in CT with a new stroke patient. So, with the hours are the same as standalone, but there seemed to be more on call in the trauma center, mostly because it was understaffed. But there are positives and negatives to being a medic in both settings, whether if it's a standalone or a trauma center. And I kind of talk to you about those positives. The positives I felt being a medic, being in the ED, is that I already had experience with difficulty patients and family members. That's huge, especially because I noticed with a lot of the new grads, they haven't really had a lot of experience dealing with um, patients or difficulty family members, unless they were maybe a nursing assistant that worked full time before they started nursing school. I noticed them They had a little better time dealing with the patient, but the difficulty family members they didn't because most of the time the RNs did. But as a medic, you already know we deal with patients, family members, you name it. Even the dogs in the house we deal with. So I felt like that was a good positive. Also, we know how to. The biggest thing I think is we know how to do an assessment, and we know to recognize when the patient is declining. I think that was probably the biggest advantage because that's when your paramedic brain flips back when you're in practice because you know how to assess. We know how to look at our patient and say, "Ooh, he doesn't look good," or "sick or not sick." We taught that in the field. We may not be able to in the field know exactly what's going on, but we know what looks normal and what doesn't. And that takes from years of experience for dealing with patients. And you come into the nursing field already with that knowledge. Another another positive is I felt comfortable with rapid response, whether if it was a cold that was happening, or whether a patient fell in the lobby, or maybe a stroke coming in. I felt comfortable with the rapid response because uh, we used to dealing with that in the field already. We used to dealing with that type of acuity when it comes to a patient. Also, we was also I felt like paramedics are ahead when it comes to skills like IV skills or hanging drips, etc. I even learned some new skills. I learned how to do an ultrasound IV, being in the ED environment, and I feel like that kind of already added to my skill set. But overall, I felt like it was just an extension of being a medic, but with more patients, and at the same time, but the medications were different. There was a lot more formulary. For example, in EMS, we didn't treat blood pressure, but in the ED we do. So you learn uh, different medications like hydralazine and things. So I felt like overall being a medic kind of helps you and kind of puts you ahead in the emergency department. Now, what's some of the negatives? I felt like I was mentioned earlier that it was really task heavy. Means you going from order to order, order to order. I remember coming in the morning and after getting a report from the nurse, I look up and all of a sudden the ED provider, has another order set, maybe some labs drawn, or this person may need to go to CT, or we may need to do a soap sus enema, or we may need to do this. And keep in mind, I got four other patients to see, or in the middle of that, EMS may bring me a new patient. Now I got a whole new order set. Or I may have one patient that I'm getting a, a report from, and I got three new patients. So now I have three new patients that I have to go run orders on. And sometimes it can feel like you would never get caught up to the end of the day. And when those patients get rooms and I'm calling a report, it can get real dicey because I don't know much about the patient because I've been running orders all day. So another one is the processes you have to learn. Like there's a different, like when you give them sedation, there's a certain way you have to chart it, and so you have to learn sedation charting using this sedation narration. Or when there's a trauma happening, someone has to chart that trauma, and so you get into trauma narrator charting. You get into code charting, or what is the code process, or how to set up for pelvic exams for the provider, or deconning patient's procedure, learning triage, and learning flow, learning where to put the patients and what rooms. And but the worst part is every ER is different. So when you go to another ED, you still have to learn their processes. But I think the worst negative for me is just holding patients because in the ED, floor nursing is different than emergency nursing. Let me give you an example. So when they are no longer under, when they switch to being inpatient, they're no longer under the care of an ED doc. They are now under the hospitalist, which can be, a medical doctor, or can be the nurse practitioner or the PA. So I was holding a sickle cell patient that was on the floor status. So the hospitalist put in that they wanted them to have a PCA pump. So They had order for PCA pump Dilaudid, and what the PCA does is the PCA lets the patient control his own dose with a lockout period for timing and dosing. Typically in the ED, we don't set those up, or even maintain those. That's usually a floor nursing skill. That's usually PCAs are usually step down units. So, but keep in mind, because they fall under the hospitalist, any order clarification always comes from them, not the ED doc. So any questions you need answered, you have to reach out to them. But what happened was this patient wanted he wanted to control his own dose. He wanted his dose up. And once we reached out to the hospitalist and he confirmed how much to increase it, none of us knew how to increase it. I literally had to call the charge nurse from step down unit to come down to walk us through a rate dose change. So that can get a little frustrating at times because of the difference in nursing practices and what we're used to and what we're not. Also, if the ICU is backed up and you holding the patient in ED that's maybe intubated and on a and, and on a vent, now you just became an ICU nurse with titratable drips. But the worst thing is you may still have your same patient load. Keep in mind the ICU ratio is usually one nurse to two patients or 1-to-1, and you may not have the staff to take over your other patient. You may not have experience dealing with the vented patients or titratable drips. But what if, like I was mentioning earlier, you don't have the staff that can relieve you of your other three patients? Now you're dealing with a ICU patient and you still have your other three patients. And I'm not saying that this is the norm. In the ED I worked at, it wasn't a norm. If you didn't feel comfortable with that patient, then you didn't get that patient. Sometimes they'll float someone from the ICUs to take care of that patient. Usually the ICU has an ICU rounder, and that ICU rounder would come down and take that patient. But I've heard in other places to where that's not the norm, and some nurses are stuck with those type of patients. And so I just wanted to give you a little deeper in-depth dive into the ED and the practices, and maybe that's some things you don't know. But what I would tell you is, while you're in school, make sure that you take advantage of your clinical rotations and really peep out and really ask around to see how the emergency department is, and hopefully that can give you a clear picture. So I'll be talking about other units in the next episode. So I'll see you then. Take care. Happy nursing. As always, hey, make sure you guys follow me on Instagram at Paramedic2RNFO. Remember the number 2.